welcome back. This is Safe Space Talk. My name is Renee. I also am known as the Inclusive Midwife on IG, and this is my beautiful co-host. This is Miss Keisha. She is known as the Hood Midwife on IG. So we're going to start off with our ceremonial little lighting of the candle, and this is for people carrying a heavy load that they are working on really hard in life, and just letting you know that we're sending out some good vibes and that we are praying for you. We're thinking about you, and we want you to know that you are uplifted, and whatever higher power you choose to believe in and serve or not, that we're sending your vibes that way, because we want you to know that whatever you're doing, we're proud of you. Get yourself a pat on the back and keep going. So today's video is one of our probably most important ones, because it's something that is not talked about a lot prior to it being in action, which is induction. So this is our induction video. We're going to go over methods of induction that are more natural, more medical, some that you can use at home whenever you're past this 37th week of pregnancy, and then some that we use in the hospitals whenever we need to use those. Beginning disclaimer before we get started. Beginning disclaimer before we get started. Beginning disclaimer before we get started. I said that 3 times, so you know it's important. We absolutely love to educate and empower everyone, but please do not utilize these methods prior to being term in your pregnancy. I cannot express that enough. So the advice and the information that we are giving you is not for you to use at 32 weeks because it's July and it's hot and you are tired and you heard about your cousin's sister's ex-girlfriend's little niece whose baby was, this proverbial kid still exists. I hear about them all the time. 24 weeks, latched onto the breast, never spent a day in the NICU and went home with them. No, that kid doesn't exist. I promise you, that was a lie. Sorry, and if it really did happen to you, like literally to you, not you heard about it happening, you can put it in the comment section and I'll apologize to you personally, but I have not yet met that person that had that 24-weeker and they just cruised right on up out of the hospital, no NICU, no intubation, nothing. So please do not use these techniques, methods, or any of these prior to 37 completed weeks of pregnancy and with your provider's permission and understanding of it. So please do not just do this for convenience and say, girl, I am so over this, 35 is close enough, I'm gonna just go ahead and get started. So we'll go over that as we continue, but please make sure that you remember that we're saying that out loud for a reason. All right, so we're gonna hand this over to Keisha. She's going to start off and she's going to go over some of the techniques that are effective but not as medicalized, and then I will pick up from that and we'll go over the ones that we typically use in the hospital more.
So we do have a few methods, as Renee said, that we can start using prior to labor that's not immediate. These things take time. These things take days to weeks to do their to complete their mission, and their mission is not necessarily active labor. It's pretty much cervical ripening. And what is cervical ripening? A cervix in pregnancy goes through some changes to make it to make your uterus a safe place for your baby to stay. And in these changes, your cervix kind of tucks itself back a little bit further. It's usually about as long as my finger, about 4 centimeters, and it's a firm consistency, and it looks like a little donut. We can throw a picture of it on here into the video. So you can see what a cervix looks like. Well, as time progresses, and if you've had several babies, different risk factors, different, just things that have happened to you in life are going to make it to where your cervix is either what we call favorable or unfavorable. Unfavorable is usually just a term we use for getting you to go into labor as far as induction, or even if you are going to labor without an induction and you are coming in spontaneous labor, that point usually your cervix is more favorable because it means you are progressing. It is doing the things that need to happen prior to either your cervix even dilating or prior to your baby being born. Yeah. So first thing that I want to talk about is membrane stripping. I offer these to 39 weeks and up, 39 completed, or 39 weeks, 39 and 0 and up is when I will begin stripping membranes if you want. Not something that has to happen. And with membrane stripping, what essentially is happening is we are doing a cervical exam. So the same way you normally would, hey, we'll check my cervix for dilation. I'm going in with my fingers, and if I can reach through, this is the big if. If your cervix is closed and tight and I cannot get my finger through, membrane stripping is off the table. I can't do it. I can't reach it. With membrane stripping, what you do is, so if you think of it, your cervix right here, and I can get my finger through, and at the inside portion of your cervix, where the water bag meets the top of your cervix words, like that, I'm going in and I'm actually kind of separating.
Like this.
Yep, I'm separating that a little bit of adhesion between the bag and the cervix, and sometimes I can actually kind of stretch the cervix out a little bit and get it to dilate a little bit more. So, you know, you might have started off as one, and as I'm stretching and stripping, you're turning into two. Now, the immediate changes is not what we're looking for at that point in time, even if your cervix doesn't change at all when I strip your membranes. What I actually want is that prostaglandin release, which is going to soften your cervix over time. And I want you to have some cramps and contractions. That is also going to make your cervix thinner, more ready, more favorable. Bring it forward a little bit. It's not tucked back to your butt. It's kind of coming forward to make that passageway ready and smooth and straight for your baby to come out. Well, straight is subjective, but straighter. So that is, in a nutshell, membrane stripping. I usually couple this with other things. I tell them to do nipple stimulation with that. So if you're leaving my office, I've just stripped your membranes. My instructions to you usually are do nipple stimulation. There are different ways you can do it. The most common way I say is if you have a breast pump, do that. And
that's what I tell them too. That's the lazy method.
Yeah,
I call it the,
you know, and for some people, they're not comfortable touching their own breasts like that, and they get weirded out. So, you know, put a pump on. And you can do I've even heard different, you know, ways. I usually say 5 minutes on, 5 minutes off for about an hour or so. And that is usually kind of coupled with that membrane stripping. In addition to that, we utilize with something that's not really an induction method, but kind of prepping your baby to make that passage is Miles circuit, M-I-L-E-S, Miles circuit. You can Google it. And it's really just a whole bunch of different positions to try to get your pelvis in optimal shape, get in balance, get your baby in an optimal position to traverse that pelvis. It is not as easy as your baby just kind of coming through that pelvis. It has very different planes it has to navigate, and it has to be in different positions to navigate those effectively and to quickly. If you are in, sometimes they can still navigate them effectively. It's just going to take a very long time because they chose a longer route. So those are things that we can do is optimization prior to labor. Other things we can do to try to get your cervix a little bit more favorable. Evening primrose oil capsules. They're like little gel capsules, and you can put them in your vagina. I say at nighttime because they do kind of melt, and you don't want to walk around with that all day.
All day.
So right when you're going to sleep, you can have you or your partner put that capsule in there, and you can do this starting at, I'd say 37, 38 weeks maybe, and it'll start softening your cervix gradually. Like I said, it's not an overnight thing for those. Things you can also do starting at around, I think it was 38 weeks is when the recommendation was red raspberry leaf tea, not commonly found in any grocery store. I got mine, a big bag off of Amazon, and I just made a pitcher of iced tea with it, and every day I would drink a glass. Now, the thought process in what's, you know, how much has been proven, I don't know. But it is well accepted in the midwifery community that it is supposed to strengthen your contractions when you do go into labor. Now, let me tell you, I didn't think it was really true. I just did it because why not? And I was cursing that red raspberry leaf tea in my induction because once it finally took over, I was like, what in the world? My uterus is clamping down like a vice and not letting go. So prepare yourself.
Like you owe it some money.
Yeah, like I owed it some money. That thing was like
Devo.
Yes. Then we move on to castor oil or a labor cocktail. There's lots of different versions you hear online. Now, castor oil is one of those highly debated ones. A lot of medical people that work in hospital are totally against it. And then you have more support on the side of the out-of-hospital births because we don't have as many methods to utilize for induction, so we're kind of left with what we're left with. Castor oil is a laxative for, you know, all intents and purposes, and what it tends to do is you take it, and if you're taking it just by itself, it's going to be a miserable time. You're going to be pooping a lot. You're going to, you know, Yeah. It is a laxative, and by it being a laxative, what it does is it makes your GI tract contract. So you're pooping, everything's releasing itself. That GI tract is contracted, and your uterus is right there next to it. And after all this contracting and irritability starts, your uterus starts doing the same thing. Also, it is increased by dehydration, which is caused by a lot of pooping. So you're dehydrated, your uterus is a muscle, it starts cramping, so you'll start getting those crampings, those contractions. Some people go into full-blown labor. Now there's a lot of places that say, hey, if you couple it with a protein, it's not as bad, you won't poop as bad. So people tend to use like almond butter
and apple butter,
yes,
peanut butter and things like
and they'll put it into cocktails with orange juice, champagne, different versions of it to make it taste better, because it's not the best tasting.
However, I will say it's not the best tasting, but there's a reason why it's castor oil as opposed to every other laxative like that you can find in any over-the-counter like drugstore. Castor oil is actually the only laxative that exists that is focused on the small intestines and not the large intestines. So the reason that it actually works is because it's a different tissue type that's in the small intestines versus the large. So whereas the large, it's focused on making stool like soak up and go around those big intestines you see in pictures and out the anus. This actually starts all the way down in the small intestines and starts moving stuff. So it's just a little bit, it's almost more direct. Like it's kind of like, okay, I'm going to shoot this person with a shotgun because it's going to be ones that spray. That's your every other laxative. But the castor oil is that sniper. They're like, no, I only need this one bullet, one shot, done, fixed it. So it starts all the way in the small intestines at the beginning and then works its way all the way out. So that's one of the reasons why it works. But I will say hydration is key with it too.
Hydrate. And because if you are planning on a hospital birth and you go in and get an IV and you get hydrated, as we said in a different episode, your uterus will be nice and happy and hydrated and good to go.
Yeah. So you'll look at it and you'll be like, I bet I won't. It has alcohol in it. That is an additive that you don't have to use. Just to throw that in there. So if you don't feel comfortable with that, it's just there to relax you on top of the contractions being strong. So it's giving you a relaxant and a calming agent plus making the uterus work.
And then lastly, on one of our more natural induction methods, we have the old faithful sex. Is what everybody always talks about. The same way you get them in is the same way you get them out.
Okay.
So I want to clarify some of that. While sex is not bad, at that time, a lot of people are just not interested. You feel full. You feel tired. You're like, that's the last thing I want to be doing.
And don't let it be your fourth or fifth baby. You're like, you've been touched all day.
Yes. You're touched
I've been
out.
clawed all day.
It's not necessarily your idea of a good time anymore at that point in time. So, with sex, things that we're really aiming for is going to be the ejaculation against the cervix. Now, that doesn't have to happen from penetration. If you're at the point where you're like definitely not having sex, if he's able to ejaculate into a container and you guys are able to get it into your vagina, that prostaglandin
you can
and that
the syringe or something.
Yep, that prostaglandin. I mean, the way the same they do those little baster babies in the hood IVFs. I'm not here to judge. You just get that semen up into the cervix.
Get it
That's
where it
the
needs
goal.
to go. IUI is fine with me.
So you're kind of letting it sit there and marinate in there and letting it soften. And that again is not an immediate process. It is a slower process, but it is one that is known to be effective. And then also we want to make sure that the woman is having the orgasm. So if you don't have a partner, and a lot of people say, "Oh, my partner's out of town. My partner's out here. Not an option." Right, deployed. Truck drivers, whatever have you, your orgasm is also important. It releases oxytocin, which is the form of hormone that everybody always hates the opposite, the pitocin, that we'll get to later. Oxytocin is the real hormone, the love drug, or the love hormone, the hormone that pretty much will get you to go into labor and start contracting. So that's why you also notice sometimes towards once you get further along in your pregnancy, once you do have an orgasm, your uterus will be really crampy and contracting. So same premises, but now we're hoping that you are further enough along and those receptors on your uterus are nice and mature and ready. To accept that oxytocin to make it cramp. So sometimes people use all of these in conjunction together and just kind of see whatever sticks. I mean, at that point, sometimes you're desperate and you just want to not be pregnant anymore. So those are some of the more natural things that we tell, or I tell my patients to do in clinic. And I'll let Renee talk about some of the more medicalized ones that we don't offer out of hospital. We don't really offer these in, birthing centers as much. Some maybe still. But these are more going to be your medicalized inductions when you're talking to a surgeon or an MD or a midwife that works in a hospital, and they're like, hey, we're inducing you on such and such date. So these are going to be the things that you can kind of look forward to maybe encountering.
Yes. Like Keisha was describing, and I described the cervix similarly. So to me, I'm a texture person, and it has to be something that I've seen before in my lifetime for me to really understand it. So I have to explain it a specific way, and I feel like for me it just works. If you can imagine your cervix, imagine a bagel, exactly a bagel in the store, except there's the hole in it is just a slit. That's about how thick your cervix is. And when we say firm, that's about the texture. It's about the texture of a bagel. Now, let's say you have the same thing, but it's a donut, and the hole is only this big. It's just like a regular donut, but the hole is this big. But a donut, if you think about it, is softer than a bagel, if that makes sense. So even though you have the bagel and it's soft and you can chew it, the donut is even softer. So that's what I mean whenever I say ripening and softening. I want to see it go from that texture of a bagel to the texture of a donut. And donuts also happen to be slimmer by more often than not, because I always call them those big Jersey bagels. Now, if it's a Jersey bagel, now boy, that's 0%. But when you see like a regular store donut, it's thinner than than the bagel is. So that's softening it and thinning it. And then you want to get that donut down to pita bread, which is how thin your cervix is if you're 90% effaced, and then a flour tortilla, which is 100% thinned out. That's how thin I want that tissue to be. So if you think about it, we're trying to get your tissue to go from the thickness and the texture of a bagel to the thinness and texture of a donut, down to a slice of regular bread, to a slice of pita bread, down to a flour tortilla. So that's how much of the work we have to do sometimes whenever you're being induced, especially if you're closed. So if you hear closed, thick, and high, that's what it is. You're that bagel consistency. So with that being said, when you come into a facility that's doing a medicalized standard procedure, the least common and the less medicalized version, I have only seen it used one time, was laminaria. So that's something that if you have kidney problems, thyroid problems, it's said not to necessarily use that.
Iodine, allergies, no-go.
Things like that. And so it's basically a dried seaweed that's got dinoprostone, which is the active medicine, and another one that we're going to go over, Cervidil. But it's an active prostaglandin E2 agonist. And so what it's going to do is it's going to go in and it's going to stay in the vagina, stay in the cervix. So we would basically shove it through your cervix as long as we could get it to fit. And it's a small stick, and it's, like I said, it's just dried out seaweed with this medicine infused in it. And then the idea is that it expands to 10 times its size. So whenever you look at it, imagine 10 of them all the way around, and that's what it's supposed to get your cervix to. So a lot of times it'll get your cervix to about that, if you can see that. I don't know if that makes sense. But it's not often used after 18 weeks for some facilities, and then some facilities will even use it a little bit later than that, but most of the time it's usually used whenever we're trying to help you with a medicalized abortion need. Or if it's a sad situation and we have a baby that's not living but still inside of the uterus and no labor has started. So Cervidil is a prostaglandin E2 as well, and what it basically does is Cervidil looks like a Converse shoestring to me. That's the way I describe it. It's like those flat shoestrings, and inside of it there's a tiny little piece that's plastic feeling, and it's very bendable. And we take that and if you can imagine, we go into your cervix. So here's your cervix. I'm taking the medicine, it's in between my fingers, I place it and I go into your cervix. But now I'm trying to go all the way back to the cervical os. I'm going in and way back. So it is not a fun placement. However, one benefit is that it's like a set it and forget it. We place it in that area and we leave you there for 12 hours with it. You don't have to do anything else. You can't make it work better or worse. It literally goes into that place. It's local, and so it only does it right there, right at that area. So that stays in for 12 hours. There's also Prepidil, which I haven't used at all. Have you ever used Prepidil? However, it's still there. It's still out there. And it's basically like Cervidil's cousin almost, except it's a gel. So instead of it being the shoestring that stays in like a tampon and it doesn't come out until we pull it out, this is a gel that actually goes inside. So it's like you're taking it and just almost like a douche. And you put it in there and it stays there. And I think that one's every 6 hours, I feel like.
So that's
6 to 8
that's
or something
interesting.
like
I
that.
think maybe we're not seeing that used a lot is because the whole point of Cervidil, in my experience, is more the safety. If you're worried about an induction, if you're worried about someone not tolerating, that shoestring, we can yank at any point in
Yank it
time.
right
If
back out.
I put gel into your vagina,
It's a done deal.
I could try to wash that stuff out, but
Yeah, you can try and douche it out, but that's one of the biggest things, and I agree, because the good thing, another good thing about Cervidil is that you go in, and if the baby is like, I bet you won't, you just like snatch it right back out, so that we can try and get that medicine effect gone. So that's the Prepidil, which is the gel version. Cervidil, which is the one that looks like a shoestring. We put it all the way back towards your rectum, as far as I can get it back there. And then the next one is Cytotec. This is a prostaglandin E1, if you want to look that up. And Cytotec is off-label use. It is technically used for GERD, reflux, things like that. However, we use it as off-label for an induction method. It does induce contractions, and it does start labor. So you can do that. It's depending on how it's dosed. It could be every 2 to every 6 hours. It can be placed by mouth. It can be placed sublingual. It can be placed buccal. It can be placed just regular oral swallowing, and it can be placed in the vagina, and it can be placed in the rectum. So I always make the joke, any hole that's there, it can be used in, except your ears and your nose. So everything else is fair game. I haven't seen where it's really used as much rectally for labor induction, but I have seen it more common with any of the oral methods and then placing it in the vagina. So that one is, however they place it, and they'll go over how often they use it. That is another medicine, though, that we cannot take back. Once we gift it to you, it's a wrap. It's already in your system, so if the baby doesn't tolerate it, then of course we need to find other methods or slow down the contractions. We're working on ways to get the baby happier. Side note, now that I'm thinking about it before I forget, every induction method, every single one, has the possibility to cause too many contractions, which can change the baby's heart rate. So hence why we demand that you're on the monitor whenever we have it going and things like that, because it's always that potential. There's medicines we can do to counteract it and make the uterus stop contracting, and hopefully most of the time that'll work. But that's why we want to make sure that we explain that. So because it all has that risk, that's why we're monitoring you, and why we care whether or not we can take it right back out. Because it's how fast can we get it? Can we take the source away and add an intervention versus just trying to add interventions on something that we could never get a chance to get back and take it away. So that's Cytotec. It usually is more than one dose. 9 times out of 10, maybe on one hand I can count how many people have had one dose and gone into labor.
People
but
had a baby or two
beforehand, but most of the time it's a multiple dose kind of thing.
And interestingly enough, I read this in a research article that it is more effective than Cervidil in women with obesity. So something to think about. If you know your patient population, that might just be a better option to kind of get shown.
Which seems weird, because you would think Cervidil being
localized,
that it would be the opposite. But if that's what it's called, a cook ripening balloon. However, you'll hear it called a Foley calf, you'll hear it a Foley bulb, you'll hear it a cook bulb, you'll hear it a cook calf. All of these different terminologies, but it means one thing, and that one thing only. So what it is it's a ripening balloon that has two balloons on it. This right here was the cook ripening balloon, and then this is your cervix. I'm going in, and then right here where you see the flame right there, we're putting that right into the cervix. And then there's a balloon back here that's going to be right behind the cervix. And then there's a balloon that's right here we can also inflate that's in front of the cervix, and it's placed in the vaginal vault. So you can imagine it's balloon, the end of your uterus where your cervix is, and then balloon right here, and that's going to be where your tampon essentially would be at. So what it does is those two balloons are supposed to compress against each other with time, and it's supposed to soften and thin the balloon, soften and thin the cervix in between, because it's got two forces kind of coming together. You'll hear a lot of myths with cook ripening balloons. A lot of times, a lot of people are like, it's only for dilation. It's actually, oh yes.
Real quick.
Perfect, yes. So yes, so that's the balloons, and we're putting it in, and we don't inflate the balloons
prior to
it looks like a regular thing, like a regular catheter, and then we inflate it when we know we're behind the cervix, and then we inflate the other one in front of the cervix if we decide to use both. So you can use one bulb or both the bulbs. It all just depends. However, like I was saying, when you have both bulbs, it's supposed to be like the fact that you have two inflated things going towards each other, so it's softening, thinning that cervix. Where they open just the one balloon, and so it's sitting against your cervix like this, and over time your cervix is like, okay, I'm going to be wide enough for this balloon to just come through. So it takes its time, and then whenever it's as wide as this, it just comes out. So it just lands into the bed. So if they do that, it's only behind the cervix, and it's just meant to open that cervix up, because it doesn't have that dual compression to squeeze the cervix thinner while that bulb's getting ready to come out. So a couple of things are different. With the bulb only on the back past the cervix, we can apply tension to it. And then when it's got both of them in there, you can't apply tension to it. So that can be longer. The bulb can be in up to 12 hours. If it's still in after 12 hour, at the 12-hour mark, they then deflate it and they'll take it out. Some places do this out of hospital. They'll actually put the bulb in. They'll only put in, I think they usually put in the one. And then they send you home, and they tell you to come back when the bulb falls out. Of all the methods, technically, the cook bulb is the one that has the least amount of correlation to contracting too frequently, also known as tachysystole. It's supposed to be the lowest chances of that happening. So a benefit is that it's also VBAC friendly, so vaginal birth after cesarean. That is one of the tools that we can use. If you've ever had a cesarean before, like the Cervidil, you wouldn't be a candidate for. The Cytotec, you wouldn't be a candidate for. The Laminaria, you wouldn't be a candidate for. Essentially, the only options you would have would be the Foley and then Pitocin, if you've had a C-section prior to. Next one, the more common one, is Pitocin. As you heard us call it,
the devil's juice.
The devil's juice, Satan's serum, all of that stuff. If you Google Pitocin, you're going to work hard to find a positive review on it. I don't know when the email went out that Pitocin was the worst thing ever, but it was also sent by the same person that said that once they started Pitocin, like even at 1, it ruined my life. I could not tolerate anything. I was dying inside. It made my contractions immediately like bam. And so just know that Pitocin is started at a low rate, and it is titrated up. So it's the idea behind it is that we're starting you out with a little bit, just like you build oxytocin in your pregnancy. You make more and more of it as you go into labor, and it goes to more and more. We're starting you out at a low dose, and we're gradually, every 30 minutes are most facilities now. I think some are still 15 minutes, but they're doing at least 15 to 30 minute breaks in between before they'll even consider going up. And we're basing how often you're contracting and how effectively your contractions seem to be to that person as to whether we're going up or not.
And I think that a lot of the stigma comes around how it was utilized. You know, some of our older nurses, I'm not going to say her name, pit the distress. That means they're pushing that Pitocin up so fast and so strong that your baby's not tolerating. And that was what they thought was a good labor pattern because it was fast. It was getting those babies out. But yes, you are stressing those little guys
Right
out, and the mom. Like, this is not a natural labor pattern. So yes, I can see where people are taking away this, like, no, this is not natural. This is not what I want. This is not how my body would do it, because it doesn't have that biofeedback. If you're making that on your own, your body's gonna be like, okay, you know, we're regulating things to an extent. We're not regulating. We're dialing up. We're dialing up on the IV. Don't blame the medicine for poor management.
Whenever they get that medicine, some places would start it, like people that have said they turned that medicine on and I was ready to just jump off the closest bridge near me, they would do like high dose pit regimen. So they would start it out at 6, which is where other facilities you won't even get to 6 until you're an hour and a half into the medicine. But they would start it at 6 and they would go up by 6 until they got to like 36, and then they would, and it's like, so for those, it, like Keisha said, the management and the titration is key. So what your facility does, that's a good thing to ask questions about. Like, how well do you manage your Pitocin whenever you get there? If I go into active labor and I'm 7 centimeters and completely thinned out and the baby is nice and low and my body is doing it on its own, do you offer me the opportunity to have that turned off and let my body continue to go on from there and see if I even still need it, things like that. So that's Pitocin, which is the most common, which is why I spent more time on that one. And the good thing about it, another good thing, like we were talking about before, if you are contracting way too fast, we can turn it down, and it's 15 minutes, you should see something. It's not going to be the full effect, but it can go down. The level will go down. And we can outright turn it off while we're doing other methods. So that's another good thing about it. And it's also VBAC friendly, or vaginal birth after cesarean friendly. And then the last one that we do often in the hospitals is AROM. So, AAROM. AAROM. It's just AROM, I'm sorry. So it stands for artificial rupture of membrane. So that's when we go in and we break your bag of water. We usually use this with the amni hook. It looks like a crochet needle. So it doesn't have a sharp part at the tip. The tiniest bit that does have like a little bit of a rougher edge to it is literally like here. Like, so my fingernail, down there where my fingernail ends. So we have to go in through, and then we literally have to grab it and pull against the water bag. So when we do that, the water will break, but your bag is tough. So sometimes we'll be down there, and people don't realize their bags are made of layers. Like, it's a layer on top of a layer on top of a layer to protect pregnancy. So we can literally be sitting there like, going at it, layers, and you're like, okay, we're gonna get to the end one day. But it usually we go in and then we turn it and then we try to catch the bag of fluid and bring it to us, and that'll make it have a hole in it. So that's another method that we use. And so with AROM, with your membranes being ruptured by us, instead of it breaking on your own while you're walking around and doing stuff at your house, there are a couple of things with it. The biggest risk, not the most common, the biggest risk is a cord prolapse, which is the same whenever your water breaks, that when we break it and the water comes shushing out, that it actually carries the umbilical cord with it. And because of just tension and force and luck and gravity, it can literally have the cord come down like your baby's head. Your baby's head is coming down. So we go in, we break the water, and then the baby's head kind of runs down. But beside the baby's head, this being your umbilical cord, because it's wrapped all around and stuff, it actually comes down like this, and the baby's head lands on it, if that makes sense. That would be cutting off the circulation, which is giving the baby their pulse. Cutting that circulation down and cutting it off, so that would be considered an emergency. Once you have a prolapse, those are the pictures that you see, like, I hate to name a show, but like any medicalized TV drama, whenever you see them running down the halls, help, open the outward, it better be because they're having an abruption or a prolapse cord. Other than I will, with my sterile gloved hand, I will take my finger out, my whole hand, and this is not the time for me to try and sugarcoat it. I'm taking my whole hand, if I can, and I'm putting it back in, and I'm pushing your baby's head up to elevate it off of that cord. And then obviously some people just want their water to break on its own. So that's totally up to them. Sometimes it will, sometimes it won't. Sometimes that's the last thing that you need to kind of get things going.
Or your baby's born in a bag.
Yeah,
You know, worst
and
case
you can
scenario,
be called.
your water never breaks and
Breaks.
your baby comes out in a bag, which is also fine.
Exactly. It was like humana, bored, another episode of Golden Girls, bored, water broke, okay, turn this mess off. And if I don't want to see Golden Girls, I know I'm in a world of hurt. So that.
I wanted to kind of finish it out by saying, although induction is necessary, sometimes it's medically indicated, sometimes it is the smartest or the safest thing for you to no longer be pregnant. Elective inductions are requested all the time. People just want to not be pregnant. I just want you to be aware that anytime you're being induced, no matter the indication, no matter the reason, your risk of having a C-section doubles, if not triples. Because like I said, we are trying to make your body do something that is very complex and we don't even fully understand. As a medical community,
we do not know.
We don't really fully understand everything about labor. We understand enough to make it happen sometimes. But there are lots of failed inductions, lots of times where it just does not work. So don't take an induction so lightly. If it is offered to you electively and you want to do it and you want to take those chances, perfect, go for it. But I don't want you to go in and then feel like your body has failed you when nothing happened, because really it was just not good timing.
It's a synthesized product that's supposed to
imitate
a natural reaction. The most common is 1 to 3 days for an induction. I think that's the biggest shocker. I think I've ruined more people's lives by telling them that inductions last sometimes, I'll say 1 hour to 3 days. Because
I'd say 4 sometimes.
I give them the 1 because there's always that random person, but I want them to see how they're thinking that they're going to go in at 9 a.m. and that they're going to have a baby at 5 because we're inducing it, and that's a work day. And it makes it, to us, we're like, no. But to that person, it makes sense. They're like, oh, okay, I'm going to the hospital for induction. This is an effective institution. They're going to have me in labor, and I'm going to have the baby by today. So their family members, I've had family members
Grandma.
like, what? I have never had or heard of anybody being in the hospital for 3 days. I know. Give your body that grace in that process, because I want to welcome and normalize days of induction so that you don't go into it with the idea, oh, my cousin's induction was 7 hours long or less than 24 hours, so will mine. It is normal for it to be 2 full days and working hard into a 3rd day. Most of the time after the 3 days, unless the baby is showing signs of distress, that's whenever they'll offer you a C-section due to a failed induction. Other than that, I've had inductions where they've tried it, they've done the balloon, they've done the Cytotec, they've done the Cervidil, they've done every medicine to the book, and the only thing they hadn't done is break their bag of water. And then they're like, it didn't work, and the lady's like, okay, well then I'll go home. And if it's not medicalized or a reason that they really need to stay right then and there, I've legit seen them just go ahead and get discharged. It didn't work. Let's go home, let my body try and marinate, process it, and then come back, and they start their induction method with more Pitocin and things like that, and then they end up having a beautiful birth, and it's just your body wasn't ready that day. If you have gestational diabetes or regular diabetes prior to being pregnant, and they look at the baby and by measurement it appears to be greater than 4,500, that would be a rationale to offer a primary C-section or a routine, or let's say it's not your first one. And then if you have no gestational diabetes or no previous diabetes, I was about to say, I remember it being more, so I was just going the 45 and 4, and this is actually 45 and 5, so like more than 5,000 grams, which would be like, I think that's 11, if I'm not mistaken.
Like 11 or 12 pounds.
Because I feel like 4,100 is right at 9, like late 9s, 10. I can't remember.
Don't ask me.
Yeah, a misconception with AAROM, we're gonna call it, is that once your water breaks, you have to be delivered within 24 hours. Have you heard that often?
Yeah, I've heard
when
that
your
a
water
lot.
breaks at home, like you have to deliver within 24 hours.
Which is not always the case. You have 18 hours until it's called prolonged rupture. And even then, at a good reputable place, that doesn't really mean much of anything other than we're watching you. We're watching you for fever, we're watching baby to see if you're getting infected, and we're watching to see if your uterus is behaving in an infected manner. But other than that, don't, think about it too much.
Over more things is to come. We're supposed to ask, I think, for you to subscribe and like.
Subscribe to our channel,
yes,
like our channel.
I have no tech savviness at all.
And that wraps up our episode on inductions. Write any questions you have below. We'll try to get back to it. And thanks for joining us today.
Bye, guys.